Everyone, so I'm back with another 5 marker question from oral medicine, which is Sjogren syndrome. So, starting with the origin and description, it was first described by Henrik Sjogren in 1933. The triad consists of keratoconjunctivitis sicca, that is dry eyes, xerostomia, that is dry mouth, and rheumatoid arthritis. There are two types of Sjogren syndrome. The first type, that is the primary Sjogren syndrome, also called the Sika complex, comprises of only the dry eyes and the dry mouth. Whereas secondary Sjogren syndrome comprises of other conditions in addition to dry eyes and dry mouth, such as systemic lupus erythematosus, polyarteritis nodosa, polymyositis, scleroderma, and rheumatoid arthritis. Etiology. There are various causes suggested, including genetic, hormonal, infectious, and immunological factors. A combination of extrinsic and intrinsic factors may contribute to this condition. An altered immunological response is considered the primary intrinsic factor. Also, the presence of anti-salivary duct antibody in their sera is a laboratory finding. Also, there is association with the HLA system. HLA-DR3 and HLA-B8 are associated with the primary form of Sjogren syndrome. And HLA-DR-W52 is associated with both the forms of the disease. Also, there are certain viruses associated like the cytomegalovirus, paramyxovirus, and Epstein-Barr virus. They have been implicated in the pathogenesis but not conclusively proven. Also, an anti-cancer drug, nivolumab, may be associated with the etiology of this syndrome. Features. It predominantly affects women over 40 years of age. Female to male ratio is approximately 10:1. It can also affect children and young adults. Typical features include dryness of the mouth and eyes due to hypofunction of salivary and lacrimal glands. Symptoms include painful burning sensations of the oral mucosa. Additional glands may be involved, like the secretory glands of the nose, larynx, pharynx, tracheobronchial tree, and vagina are also affected, leading to dryness, also called the buccopharyngolaryngitis sicca. There are elevated levels of IgA, potassium, and sodium in the saliva of these patients. Then, about 80% of patients with primary Sjogren syndrome show parotid enlargement, whereas only 14% of patients with secondary Sjogren syndrome have parotid enlargement. Lymphadenopathy is twice as common in primary Sjogren syndrome compared to that of secondary form. Rheumatoid arthritis is an integral part of secondary Sjogren syndrome, and patients with rheumatoid arthritis have different clinical manifestations compared to those with Sika complex. Few common features of the secondary Sjogren syndrome are fatigue, arthralgia, myalgia, neurological symptoms, nephrological symptoms, and skin rashes. Oral manifestations include ulcers and mouth sores, dental caries, periodontal diseases, bad breath, candidal infection, burning sensation, difficulty in speaking, difficulty in swallowing, all due to xerostomia. Histologic features. There are three types of histological alterations. There can be intense lymphocytic infiltration of the gland, replacing all acinar structures while preserving the lobular architecture. There may be formation of myoepithelial islands due to proliferation of ductal epithelium and myoepithelium. Or there may be simple atrophy of the glands as a consequence of lymphocytic infiltration. Then coming to the diagnostic criteria. First, if the minor salivary gland biopsy, that is, biopsy taken from the lower lip, if it shows focal lymphocytic sialadenitis with a focus score of more than or equal to 1, here focus score refers to the number of lymphocytic foci per 4 mm square of glandular section. Then a score of 3 should be allocated. If the anti-SSA or anti-Rho factor is positive, then again a score of 3 should be allocated. If the ocular staining score is greater than or equal to 5 or greater than 4 according to the Van Bistervel's scoring system in at least one eye, then a score of 1 should be allocated. If the unstimulated salivary flow is less than or equal to 0.1 milliliters per minute, then a score of 1 should be allocated. And if the Schirmer's test showing less than 5 millimeters of tear production in 5 minutes in at least one eye, then a score of 1 should be allocated. If the total score is more than 4 points, then it can be diagnosed as Sjogren syndrome. To investigate the disease, like tests for xerostomia, are low force spitting or drooling method and absorbent or swab method to test the whole saliva, and Carlson cretendon collector and Lashley's copper cannula to test the parotid saliva. Then tests for xerophthalmia include the dye test like Rose Bengal dye test and Lissamine green dye test, and other two tests are Schirmer test and tear film breakup time. Other investigations like cylometry, the salivary flow rate in these patients at rest is 0.1 ml per minute, and when stimulated it is 0.7 milliliters per minute. Xylography shows the characteristic appearance of widespread dots or blobs of contrast medium within the gland known as punctate sylectasis or snowstorm or cherry blossom or branchless root-laden tree appearance. The cause of such an appearance is the weakening of the epithelium lining the intercalated ducts, allowing the escape of the contrast medium out of the ducts. Scintigram shows an area of cold spot on the scan. To manage this disease, currently there is no single satisfactory treatment that has proven to be effective in modifying the course of the disease. Most patients are given palliative treatment, that is, provided symptomatic relief. Keratoconjunctivitis is treated by moisture replacement therapies, that is, installation of ocular lubricants such as artificial tears containing 0.5% methyl cellulose 4 to 5 times daily should be used. Additionally, cyclosporine restasis helps to treat chronic dry eye by suppressing the inflammation that disrupts tear secretion. Of dry mouth, there are various symptomatic therapies such as secretagogues, oral rinses and gels, mouthwashes, artificial saliva, and water sipping. There are two FDA-approved medications which induce a transient increase in salivary output. First is pilocarpine 5 milligrams 4 times a day and sevimilin 30 milligrams 3 times a day. Salivary substitutes such as carboxymethyl cellulose and intake of citrus fruits is recommended. Brand name of such a salivary substitute is wet mouth. Scrupulous oral hygiene and frequent fluoride application is indicated to reduce the dental problems associated with xerostomia. For candidiasis, topical nystatin 3 times a day for a week, ketoconazole 200 to 400 milligrams daily, or fluconazole 50 to 100 milligrams daily, or itraconazole 100 milligrams daily for 2 weeks. Thank you for watching. If you like this video, please subscribe to my YouTube channel. Stay tuned for more such videos.